Okay, let's unpack this. Imagine taking something utterly essential for life, oxygen, and transforming it into a precise, powerful therapeutic agent. We're not just talking about, breathing extra oxygen. We're talking about delivering it under pressure. This is hyperbaric oxygen therapy, or HbO2.
And today we're pushing past the list of approved conditions, diving into the absolute heart of the matter, the fundamental mechanisms of action. How does putting someone in a pressurized environment, breathing pure oxygen, actually change biology at the cellular and molecular level to achieve those clinical effects?
That's the mission. And our guide, our absolute deep dive source for this session, is specific. It's the chapter titled Mechanisms of Action, written by true experts in the field, Gerardo Bosco, Giuliano Visani, and Enrico M. Camporesi.
For you, the specialist clinician, our goal is an unabridged understanding. We are going to pore over every single detail, fact, proposed mechanism, guideline nuance, controversy, and clinical pearl presented within this text. Think of this as extracting the maximum knowledge density from this specific source, exploring the why and the how in, well, microscopic detail.
So where are we going? We'll start with the absolute bedrock, the foundational physics and the historical context that first brought this therapy into view. Then we'll ascend to the cellular and tissue levels, exploring how this unique environment influences the growth of new blood vessels and boosts the survival of tissues facing injury.
Right, and we'll tackle its direct and indirect confrontation with bacteria and its incredibly complex interactions with inflammation.
And we'll wrap up by venturing into some truly cutting-edge concepts, including its potential roles in pain relief, bone formation, and the frankly revolutionary idea of cell-to-cell mitochondrial transfer.
It's quite a journey, from gas laws you probably learned way back in physics all the way to intercellular organelle dynamics. Let's begin.
The very foundation, the core concept that initiates all the complex downstream mechanisms of hyperbaric oxygen therapy is the elevation of the partial pressure of the inspired oxygen. It sounds straightforward maybe, but it's critical to grasp that this isn't just about breathing 100% oxygen. It's the synergistic effect of two factors working together.
Exactly. You're increasing the inspired oxygen fraction to 100% within the chamber, yes. But you are simultaneously increasing the hydrostatic pressure, the ambient pressure of the environment itself. The combination of these two factors dramatically elevates the partial pressure of oxygen available to the body compared to, breathing air at normal atmospheric pressure.
And the practical clinical utilization of this high-pressure oxygen is firmly rooted in fundamental physiological principles. Specifically, as the source highlights, the basic gas laws of Boyle, Dalton, and Henry. Thinking back to these from your training is essential because they directly govern how gases behave in the body under these, well, pretty unique conditions.
Let's just quickly grind ourselves with those. Boyle's law tells us that for a fixed amount of gas at a constant temperature, the volume is inversely proportional to its pressure. So when you increase the ambient pressure around the body in a hyperbaric chamber, any gas bubbles present, whether from arterial gas embolism or decompression sickness, are physically compressed.
It gets smaller.
Right. Their volume decreases proportionally to the increase in absolute pressure. It's like taking a balloon and pushing it into a much denser environment. It just gets smaller.
And Dalton's law of partial pressures states that in a mixture of gases, the total pressure is the sum of the partial pressures of each individual gas. In a hyperbaric chamber pressurized to, say, 3 atmospheres absolute and breathing 100% oxygen, the partial pressure of oxygen is effectively the total pressure, minus the minimal contribution of water vapor and carbon dioxide from the lungs.
Which means it's huge, far exceeding the sum of all gases combined at normal atmospheric pressure.
Which directly leads us to Henry's law. This is arguably the most critical for understanding systemic and tissue oxygen delivery under hyperbaric conditions, isn't it?
Oh, absolutely. Henry's law states that the amount of gas that dissolves in a liquid is directly proportional to the partial pressure of that gas above the liquid. Under normal breathing conditions, with the relatively low partial pressure of oxygen in the air, most oxygen transported by the blood is chemically bound to hemoglobin within red blood cells. Only a tiny amount is physically dissolved in the plasma.
But under hyperbaric pressure, the inspired oxygen partial pressure is orders of magnitude higher. Following Henry's law, this enormous gradient drives a significantly larger amount of oxygen to dissolve directly into the plasma. This dissolved oxygen then becomes a primary vehicle for delivering oxygen to tissues.
And it can diffuse across longer distances, get into areas with poor blood flow or capillary density.
Yeah.
It basically bypasses the limitations of hemoglobin binding and red cell delivery.
Yeah, imagine the plasma itself becoming saturated with freely available oxygen molecules, just ready to jump into any surrounding tissue.
This perspective shift is quite powerful, and the source frames it compellingly. Thinking of oxygen itself as a drug and the hyperbaric chamber as the precise, sophisticated dosing device, you're administering oxygen not just in higher concentration, but under physical conditions that fundamentally alter its pharmacokinetics and pharmacodynamics within the body, allowing for effects you just can't get at normal pressure.
And this concept isn't entirely new, is it? The historical context laid out in the source shows this understanding evolving over time. As early as 1939, Yarbrough and Benka documented the use of hyperbaric oxygen therapy specifically for decompression sickness, directly applying Boyle's law to bubble compression.
Right, that was the initial big application. But the significant expansion of hyperbaric medicine beyond diving-related issues to treat other pathologies truly took off between 1955 and 1962. A notable early application, highlighted in 1955, was considering pressurized oxygen as an adjunct therapy to boost the effects of radiotherapy in cancer patients.
Why was that?
Based on observations that well-oxygenated tumors were more sensitive to radiation. Made sense, theoretically.
Okay, and just a year later, in 1956, in the Netherlands, a groundbreaking clinical application emerged, using hyperbaric oxygen therapy to extend the duration of circulatory arrest during surgery for congenital cardiovascular defects.
Yeah.
By hyperoxygenating the patient's tissues before stopping circulation, surgeons gained precious extra time to perform complex repairs.
And that use, directly supporting surgery, drew immense attention worldwide. It was a real game changer for visibility.
I bet.
That international attention was a catalyst. It spurred the installation of large, multi-place hyperbaric chambers in hospitals and research centers globally and significantly boosted further investigation into therapy, particularly for surgical support and other acute conditions.
Also stemming from the Netherlands, clinicians observed a dramatically positive clinical response in patients suffering from gas gangrene caused by Clostridia infections when treated with HBO2. This clinical observation was pivotal because it directly prompted systematic studies into the antimicrobial activity of hyperbaric oxygen therapy, a mechanism we'll definitely delve into later.
And in the early 1960s, Smith and Sharp pioneered the use of HBO2 for carbon monoxide poisoning. Their initial reports were striking, highlighting apparent reversal of cardiac impairment, significant improvements in neurologic outcomes, and a measured acceleration of carbon monoxide removal from hemoglobin and tissues, basically leveraging the high oxygen partial pressure to physically displace the carbon monoxide.
So the clinical improvements patients experience are directly attributable to these elevated oxygen partial pressures. When lung function is relatively normal, hyperbaric oxygen therapy sessions at 2 to 3 atmospheres absolute, which is equivalent to 202.6 to 303.9 kilopascals, can achieve an arterial partial pressure of oxygen, or arterial PO2, typically in the range of 1,000 to 1,500 mmHg.
Which is, as you know, just orders of magnitude higher than the normal arterial PO2 of around 80 to 100 mmHg when breathing air at sea level. This super physiological level of dissolved oxygen is the driving force behind many of the downstream effects.
Now, for patients presenting with bubble-related diseases, like arterial gas embolism, where air or gas enters the arterial system, or decompression sickness, where dissolved inert gas comes out of solution to form bubbles due to rapid pressure reduction,
Hyperbaric oxygen therapy offers a very specific, immediate benefit via two mechanisms rooted in those gas laws.
First, as we mentioned with Boyle's law, raising the ambient pressure physically decreases the size of those gas bubbles lodged in blood vessels or tissues. This can reduce mechanical obstruction and tissue damage pretty quickly.
And second, and equally important in these acute settings, systemic hyperoxia throughout the body leads to a significant decrease in the partial pressure of inert gases, like nitrogen, within the body's tissues and blood. This establishes a massive diffusion gradient.
So the gas wants out of the bubble.
Exactly. The inert gas from the bubble, now at a relatively higher partial pressure compared to the surrounding hyperoxygenated environment, is driven out of the bubble and into the tissue and blood, where it can be transported away and exhaled. It's like shrinking the bubble while simultaneously accelerating its dissipation. Now, here's a crucial distinction highlighted in the source, particularly relevant for you as a specialist clinician focused on chronic indications. While bubble resolution is the primary life-saving mechanism in acute arterial gas embolism or severe decompression sickness, most patients who benefit from hyperbaric oxygen therapy over days and weeks for conditions like non-healing wounds or chronic radiation injury do not benefit because of reversal of bubble-induced injuries.
Right, that's a really key clinical pearl. Their improvement stems from the favorable biological response to the sustained, albeit intermittent, elevation of oxygen pressure over multiple exposures. The dramatic, rapid increase in arterial, cellular, and venous PO2 achieved during a session is acute. Those effects are short-lived and quickly return towards baseline after the pressure is normalized and the patient breathes air again.
Therefore, it's widely accepted, as noted in the source, that the profound, longer-lasting effects of hyperbaric oxygen therapy, the ones that facilitate healing and tissue repair over time, must be mediated by secondary biological effects. These aren't simply due to a transient increase in tissue oxygen tension.
There's something more complex.
Exactly. These are effects that accumulate over hours and days of repetitive exposure, aligning with Kinwall's description of them as pharmacological effects. This means HBO2 is initiating cellular and molecular processes that persist and build upon each session, like a drug building up effect.
Now, because oxygen can indeed be toxic, inducing oxygen toxicity affects the central nervous system and lungs, its administration during hyperbaric oxygen therapy is carefully limited empirically. These limits are defined by the total pressure reached and the duration of the exposure. It's a balancing act.
Absolutely. The typical clinical dosing protocols, which have been refined over decades, usually involve sessions of 1 to 4 hours per day, most commonly administered at pressures between 2 and 3 atmospheres absolute, or 202.6 to 338.9 kilopascals. The clinical objective is always to titrate the exposure, the dose and duration to induce the desired favorable biological responses that accumulate over time, while carefully minimizing the potential for acute oxygen toxic effects, whether affecting the central nervous system or the pulmonary system.
Let's look at Figure 1 from the source, which visually represents the relationship between blood PO2 and oxygen content in human blood during hyperbaric oxygen therapy. It's a really powerful illustration of Henry's law and its clinical significance.
Yeah, the graph clearly shows the two ways oxygen is carried in the blood. First, you see the curve representing oxygen combined with hemoglobin. This curve rises steeply initially, but quickly saturates and plateaus around a PO2 of 80-100 mmHg. Hemoglobin has limited binding sites. Once it's full, it's full. It can't carry much more oxygen, regardless of how high the PO2 gets.
But then you see the second component, dissolved oxygen in plasma. This portion is represented by a line that just increases linearly with rising partial pressure of oxygen. At normal atmospheric pressure, this dissolved amount is relatively small, almost negligible in terms of bulk delivery. However, under hyperbaric conditions, with arterial PO2 reaching 1,000-1,500 mmHg and above, the amount of oxygen physically dissolved in the plasma becomes very substantial.
And this vastly increased dissolved oxygen is the critical factor enabling oxygen delivery to tissues under pressure. It can diffuse across greater distances from capillaries, reach areas with limited red blood cell flow, and saturate interstitial fluid in cells, effectively bypassing the normal hemoglobin-dependent transport system when that system is insufficient, like in ischemic or poorly perfused tissues.
It's like having a reservoir of free oxygen molecules saturating the entire extracellular environment, making oxygen available where red blood cells might struggle to reach.
Now, here's where things get potentially complicated and maybe a bit counterintuitive. Administering oxygen at pressures exceeding 1 atmosphere absolute, or 101.3 kilopascals, inevitably leads to the production of reactive oxygen species, or ROS. These are molecules like superoxide and hydrogen peroxide, often associated with oxidative stress and cellular damage.
The bad guys of metabolism, usually.
Often, yes. And yet, the source states unequivocally that this controlled production of reactive oxygen species undoubtedly represents a central molecular mechanism for many of the therapeutic pathways of hyperbaric oxygen therapy. So instead of just being harmful, HBO2 seems to harness ROS as signaling molecules.
Yeah, exactly. Reactive oxygen species, along with reactive nitrogen species, or RNS, are increasingly recognized not just as damaging agents, but as crucial signaling molecules. They participate in complex transduction processes that regulate the activity of different growth factors, cytokines, and hormones within cells.
So by generating specific dose-dependent levels of ROS, hyperbaric oxygen therapy is essentially using these molecules to trigger beneficial cellular responses and signaling cascades. It's weaponizing ROS in a way for good.
Okay, so let's quickly recap section 1 before we move on. We established the fundamental physics governed by Boyle, Dalton, and Henry, explaining how the combination of 100% oxygen and increased ambient pressure dramatically elevates oxygen partial pressure.
Right, and we saw, like in figure 1, how this leads to a significant increase in dissolved oxygen in plasma, bypassing hemoglobin transport limitations.
We reviewed key historical milestones, from decompression sickness to surgical support and gas gangrene. Crucially, we distinguished the acute bubble compression effects from the chronic, cumulative pharmacological benefits requiring repetitive exposure, and noted the dose limits to avoid toxicity.
And finally, we introduced the really important concept of reactive oxygen species production as a central signaling mechanism, not just a byproduct, driving many of HbO2's therapeutic effects.
Right. Moving now to the tissue and cellular level, one of the most successful and clinically established applications of hyperbaric oxygen therapy, and where many of these mechanisms really converge, is in promoting non-healing wound repair.
Yeah, the source specifically highlights two types of challenging tissue lesions where HbO2 has been extensively studied and applied: diabetic wounds and post-radiation delayed tissue injuries. Very difficult clinical problems.
What's remarkable is that despite differing underlying causes, diabetes involves microvascular disease and impaired cellular function, while radiation causes chronic damage to blood vessels and connective tissue. These non-healing wounds share common characteristics. They both exhibit depletion of critical stromal cells needed for tissue structure, poor formation of granulation tissue on the wound surface,
Persistent chronic inflammation that hinders repair, and excessive fibrosis, leading to stiff, non-functional tissue, basically a stalled wound.
and critically, both types of wounds also share a reduced supply of both oxygen and the necessary mediators like growth factors and immune cells required for effective healing. They are essentially stuck in a pathological cycle, unable to progress through the normal stages of repair. Imagine a wound environment that's chronically starved and just lacks the right signals to get going.
Hyperbaric oxygen therapy intervenes by positively impacting both of the key processes necessary for neovascularization, the formation of new blood vessels, which is absolutely essential to bring oxygen, nutrients, and immune cells into the wound to support healing.
So what are those two processes?
First, HbO2 promotes angiogenesis. This is the process where new blood vessels sprout and grow from the existing local endothelial cells at the wound margins. HbO2 helps stimulate these existing cells to start extending and forming new capillaries.
And second?
Second, it enhances the recruitment and differentiation of circulating stem or progenitor cells. These are cells mobilized from, say, the bone marrow or peripheral blood that travel to the wound bed and differentiate into endothelial cells and other cell types needed to build new blood vessels and connective tissue.
And HbO2 helps with that mobilization.
Yes, it's been shown to improve the impaired vascularization often seen in diabetes and reverse the diminished mobilization of these crucial stem and progenitor cells caused by radiation and chemotherapy exposure. It helps get the building blocks to the site.
There's also a separate but related mechanism where the HbO2-induced oxidative sites, those areas where a controlled burst of reactive oxygen species is occurring, actively stimulate the production of growth factors specifically by the stem and progenitor cells within the wound bed. So ROS, again, linking back to healing.
Exactly. It's a recurring theme.
Right.
Now, a significant part of this neovascularization mechanism is specifically attributed to the additional synthesis and stabilization of hypoxia-inducible factor, or HIF.
Now, this is genuinely fascinating because HIF transcription factors are intracellular proteins, typically induced and stabilized by hypoxia. Under normal oxygen conditions, they are rapidly degraded. That's their whole point, isn't it? To sense low oxygen.
Precisely. And yet, hyperbaric oxygen therapy, which induces systemic and tissue hyperoxia, leads to the stabilization of HIF. The source explains this apparent paradox. HIF requires the expression of free oxygen radicals, probably as an induced response involving the antioxidant enzyme thioredoxin and its regulatory enzyme, thioredoxin reductase.
So the controlled oxidative stress generated by HbO2 seems to somehow modulate this thioredoxin pathway, leading to HIF stabilization even when oxygen levels are high. It's a complex regulatory loop where oxygen, paradoxically helps stabilize a hypoxia sensor via intermediaries.
Wow.
It is complex. It's also noted that oxidative stress originating from lactate metabolism within tissues can independently trigger this same pathway involving HIF stabilization. So, multiple inputs potentially leading to HIF activity even under hyperoxia.
Okay, beyond this intriguing HIF pathway, does HbO2 stimulate other growth factors too?
Yes, it also stimulates the synthesis of other specific growth factors, vital for tissue repair and regeneration. These include basic fibroblast growth factors, evolving growth factor B1 produced by human dermal fibroblasts, and basic fibroblast growth factor observed in ischemic limbs. These are all powerful signaling molecules that promote cell proliferation, migration, and the deposition of extracellular matrix needed for wound closure and tissue remodeling. However, while these effects are clearly observed and contribute to clinical outcomes, the authors emphasize a critical point for clinicians.
Which is?
Additional studies are still needed to refine the timing and optimal doses of hyperbaric oxygen therapy. This is crucial for maximizing these specific pro-neovascularization effects in clinical practice.
So even though we understand the underlying biological pathways reasonably well, fine-tuning the therapeutic delivery to best harness them is an ongoing area of research and clinical optimization. We know what happens, but optimizing how we make it happen is still key.
Right. Let's do a micro recap for Section 2. We've seen how hyperbaric oxygen therapy significantly aids the repair of challenging non-healing wounds, like those in diabetes and post-radiation states, by promoting neovascularization. It does this through two key processes: stimulating angiogenesis from existing vessels and enhancing the recruitment and differentiation of circulating stem cells to the wound bed.
And a remarkable mechanistic insight is the paradoxical stabilization of hypoxia-inducible factor, or HIF, by HbO2-induced reactive oxygen species via the thioredoxin pathway. HbO2 also boosts other vital growth factors.
But despite these clear pathways, optimizing clinical timing and dosing to maximize these specific effects remains an active area of study.
Okay, moving on to the critical issue of preserving tissue survival after insufficient blood supply, or ischemia, clinical results have consistently documented significant recovery with hyperbaric oxygen therapy in several scenarios following ischemic injury.
This includes documented successes in complex procedures like extremity reimplantation and free tissue transfer, where restoring blood flow is paramount, but the subsequent reperfusion itself can cause significant damage. It's also relevant in general injury and reperfusion scenarios affecting various tissues.
The source also suggests potential application and benefit in visceral organs. Specific examples cited from the literature include reports of hyperbaric oxygen therapy reducing coronary artery restenosis, the re-narrowing of arteries after balloon angioplasty and stenting,
and increasing the amount of myocardial tissue salvaged or rescued after thrombolytic treatment following an acute myocardial infarction, a heart attack.
Now, for you, the specialist clinician, it's important to immediately note the critical qualifier the source attaches to these specific visceral examples. These data are considered preliminary and need further verification.
Okay. So promising, but not quite prime time yet for those specific applications.
Exactly. While promising and supported by some studies, these aren't presented with the same level of robust, multi-study evidence as, say, the established role in wound healing or bubble disease. It's an area of potential, but still requiring more definitive data.
Got it. So what's a primary mechanism for how HbO2 limits tissue injury after ischemia reperfusion?
A major one, and well-established, is by directly preventing some of the most harmful consequences of the reperfusion phase itself. A major contributor to reperfusion injury is the excessive adherence of circulating neutrophils, a key type of white blood cell involved in the inflammatory response to the vascular endothelium, the inner lining of blood vessels.
They stick too much.
Right. This sticking is largely mediated by specific cell surface molecules on the neutrophils called beta-2 integrins. Imagine these inflammatory cells clogging up the microvasculature and releasing damaging enzymes and reactive oxygen species upon reestablishing blood flow. It's a big part of the damage.
And HbO2 stops this.
Exposure to hyperbaric oxygen therapy causes significant inhibition of this neutrophil adherence to the endothelium. The source lists a wide array of subsequent biological advantages that result from this reduced sticking, including improved reperfusion, better blood flow after injury in the brain, heart, lung, liver, skeletal muscle, and intestines.
That's a broad range of tissues.
It is. It's also linked to reduced injury in specific clinical contexts, such as decreased smoke-induced lung injury and reduced encephalopathy brain dysfunction due to carbon monoxide poisoning. Furthermore, it contributes to the beneficial effects seen in decompression sickness and reperfusion injury that can follow gas embolism, reinforcing the multifaceted nature of HPO2's actions even in acute bubble situations.
Okay, so what is the molecular basis underpinning this beneficial selective inhibition of neutrophil adherence? How does HPO2 actually stop them sticking?
The source explains it is mediated by the increase of reactive oxygen species derived from inducible NO synthase, or INOS, and myeloperoxidase. There's ROS again.
It keeps coming back.
It does. This specific ROS production pathway leads to a critical downstream effect, S-nitrosylation of cytoskeletal beta-actin. Beta-actin is a fundamental component of the neutrophil's internal structural scaffolding, its cytoskeleton. S-nitrosylation is a post-translational modification where a nitric oxide group is added to a specific cysteine residue on the beta-actin protein.
So it modifies the structural protein inside the neutrophil.
Yes, and while this modification increases the concentration of short, non-cross-linked filamentous actin within the cell, essentially changing the internal structure dynamics here is the key clinical benefit and why this inhibition is selective. The source explicitly states that this modification shows no change in neutrophil viability and their core defense capability.
Wow, that's crucial.
It is. Their ability to perform phagocytosis engulfing bacteria and cellular debris, and their oxidative burst activity generating toxic oxygen metabolites to kill ingested pathogens in response to chemoattractants remains fully intact. HPO2 inhibits their ability to adhere excessively and cause reperfusion damage, but it preserves their essential function in fighting infection.
This preservation of antibacterial function is a crucial distinction when you compare this mechanism to alternative ways of inhibiting beta-2 integrins, such as using monoclonal antibodies, right?
Absolutely. Monoclonal antibodies designed to block beta-2 integrins can also effectively ameliorate ischemia reperfusion injuries by preventing neutrophil sticking. They work. But, as the source highlights, and this is a significant clinical difference, in contrast to hyperbaric oxygen therapy, systemic antibody therapy targeting beta-2 integrins typically causes generalized immunocompromise because it blocks the essential adhesion function neutrophils need to get to sites of infection. You blunt their ability to fight bugs everywhere.
Whereas HPO2 doesn't do that.
Correct. Hyperbaric oxygen does not inhibit neutrophil antibacterial functions because the G-protein-coupled pathway required for endoplasmic activation, which is involved in processes like the oxidative burst and directed migration towards pathogens, remains intact despite the specific actin modification. This selective action is a major advantage in clinical situations where patients are already vulnerable to infection or where infection is part of the underlying pathology, like in chronic wounds.
Okay, that makes a lot of sense. The source also introduces what appears to be a separate, though potentially related, anti-inflammatory pathway for hyperbaric oxygen therapy. What's that about?
This involves impaired production of pro-inflammatory cytokines, specifically by monocyte macrophages, another type of immune cell.
So they make fewer inflammatory signals.
Essentially, yes. This process can lead to a measurable reduction in circulating pro-inflammatory cytokines under various stress conditions. The postulated molecular mechanism in this area is the enhancement of protective proteins known as heme oxygenase 1 and heat shock protein 70, both of which are known to dampen inflammatory responses.
Right, the cellular stress response proteins.
Exactly. Finally, the source mentions that hyperbaric oxygen therapy has been consistently shown to increase the ischemic tolerance of multiple organs in numerous animal models. This means tissues are more resilient and better able to survive periods of reduced blood flow if they have been pre-exposed to HPO2.
And the mechanisms for that.
The mechanisms underlying this increased tolerance involve the induction of antioxidant enzymes, which help cells cope with the oxidative stress that occurs during both ischemia and reperfusion, and the induction of anti-inflammatory proteins, like those we just discussed, reducing the damaging inflammatory cascade. It's about boosting the cell's defenses beforehand.
Okay, micro recap for section 3 then. Hyperbaric oxygen therapy improves tissue survival after ischemia, with established benefit in areas like extremity salvage and promising preliminary data for visceral organs.
A core mechanism is the inhibition of neutrophil adherence to endothelium, driven by reactive oxygen species from INOS and myeloperoxidase, leading to S-nitrosylation of beta-actin.
Crucially, this inhibition is selective because, unlike antibody approaches, it prevents damaging sticking while preserving the neutrophil's vital antibacterial function, a key clinical advantage.
Right. HbO2 also reduces inflammation via monocyte macrophage pathways and enhances overall organ ischemic tolerance by inducing antioxidant and anti-inflammatory proteins.
Okay. Shifting focus now to hyperbaric oxygen therapy's direct and indirect fight against microorganisms, its bacteriostatic and bactericidal effects. The therapeutic impact on anaerobic bacteria seems particularly well understood.
It is. The primary mechanism here is quite straightforward and relates directly to oxygen toxicity. High oxygen partial pressures exert a substantial and direct bactericidal effect they kill upon obligate anaerobic microorganisms.
Because they just can't handle the oxygen.
Exactly. This is due to their fundamental metabolic limitations. Obligate anaerobes cannot survive in the presence of significant oxygen because they lack the necessary enzymatic machinery key scavenger enzymes like superoxide dismutase and catalase that aerobic and facultative anaerobic bacteria possess to detoxify the reactive oxygen species that are inevitably generated in the presence of oxygen.
So they get poisoned.
Pretty much. This lack of defense makes them exquisitely vulnerable and effectively poisoned by the high concentration of oxygen-free radicals produced under hyperbaric conditions. Imagine oxygen as a toxic gas that these specific bacteria simply cannot neutralize.
A study by Zanin and colleagues, cited in the source, provided direct evidence for this pressure-dependent killing. They examined the growth of various bacterial strains in cultures exposed directly only once to either hyperbaric oxygen therapy conditions or normal atmospheric pressure. They specifically looked for changes in the minimum inhibitory concentration, or MIC.
The lowest concentration of an antibiotic that inhibits visible growth.
Right, and the minimum bactericidal concentration, or MBC.
The lowest concentration that kills 99.9% of the bacteria.
Of multi-resistant microorganisms after a single HbO2 session. And what did they find?
Their key finding was clear and confirms the importance of pressure. Hyperbaric oxygen therapy is bactericidal only if the total oxygen exposure pressure is elevated. Normobaric 100% oxygen might be bacteriostatic for some, inhibit growth, but the pressure component is necessary for direct killing of anaerobes as described.
So it's the hyperbaric part that really does the killing for anaerobes.
It underscores that it's the hyperbaric environment, enabling those high oxygen partial pressures and subsequent ROS generation that's essential for this direct effect on susceptible organisms.
Now, the situation is different for aerobic bacteria like Staphylococcus aureus, a common culprit in many infections, including chronic wounds and bone infections, isn't it?
It is. A study by Mater, also referenced, looked at the effect of HbO2 in an animal model of osteomyelitis bone infection caused by Staphylococcus aureus in the rabbit.
And what were the findings there? Was it straightforward?
Initially, the results from this study were somewhat counterintuitive and highlighted the complexity. The study reported negative findings in vitro, meaning in a lab dish. Hyperbaric oxygen therapy had no direct antibacterial effect against Staphylococcus aureus when they were simply exposed to the hyperbaric oxygen environment in isolation.
So HbO2 doesn't kill staph directly in a dish.
Correct. Furthermore, acutely, HbO2 failed to significantly influence blood flow in the infected bone during the session itself. So no direct killing, no immediate blood flow boost in the infected area. Kind of puzzling at first.
However, the study found that hyperbaric oxygen therapy was effective in treating staphylococcal osteomyelitis in the living animal. The explanation provided illuminates a crucial indirect mechanism. HbO2's efficacy was not due to direct killing of the bacteria by the high oxygen, but because it increases the intramedullary oxygen tension, the oxygen level within the bone marrow environment where the infection resides.
So it changes the local environment in the bone.
Exactly. This increased local oxygen tension in the infected bone marrow reached levels high enough to enable the host's own immune cells, specifically polymorphic nuclear leukocytes, or neutrophils, to effectively kill the bacteria.
Because neutrophils need oxygen for their killing mechanism.
Precisely. Staph aureus is aerobic, but the hostile environment needed for neutrophils to kill them using oxidative mechanisms requires sufficient oxygen at the site of infection, which can be hypoxic in infected bone. HbO2 didn't kill the staph directly. It corrected the local oxygen deficit, creating an environment where the immune system's oxygen-dependent killing mechanisms could finally function effectively.
It's like supplying the immune army trapped in the bone marrow with the oxygen they desperately needed to fight. Makes sense.
The Mater study went on to detail specific neutrophil effects confirming this. A single 90-minute HbO2 exposure caused an increase in the respiratory burst activity of neutrophil-like cells. After the exposure, that's the process they use to generate a burst of reactive oxygen species to kill pathogens. It also increased the phagocytosis, the engulfing of Staphylococcus aureus by these cells.
The source also notes a fascinating dual role. Hyperbaric oxygen therapy contributes to both this enhanced antimicrobial activity and cellular apoptosis, or programmed cell death. Now, at first glance, enhanced bacterial killing, often involving pro-inflammatory oxidative bursts, might seem detrimental to healing, potentially increasing inflammation.
Yeah, you'd think more killing equals more inflammation.
Right, but the source explains the necessary balance. Enhanced apoptosis, the controlled clearing of cells, helps to resolve inflammation. By promoting the non-inflammatory clearance of activated immune cells and debris, apoptosis supports overall wound healing and may offset any potentially detrimental pro-inflammatory effects stemming from the increased antimicrobial activity.
So it ramps up the attack, but also ramps up the cleanup crew.
That's a good way to put it. It's a complex interplay where a necessary cleanup process counterbalances the heightened immune attack.
Okay. What about bacterial biofilms? They're notoriously difficult.
They are. Bacterial biofilms present another significant challenge, particularly in chronic infections and non-healing wounds. These are structured communities of bacteria embedded within a self-produced matrix, often characterized by hypoxic zones within the biofilm structure, which can shield the bacteria from immune cells and reduce the effectiveness of antibiotics.
Does HBO2 help with biofilms?
The source acknowledges that the specific mechanisms by which hypoxia within biofilms influences their vulnerability to antibiotics are still uncertain. However, evidence suggests a potentially valuable synergy. The effectiveness of several bactericidal antibiotics appears to be increased by hyperoxia, perhaps, again, related to increased reactive oxygen species production or improved antibiotic penetration into the biofilm matrix under these conditions.
So it might make antibiotics work better against biofilms.
That's the idea. Specific examples cited in the source include studies showing that hyperbaric oxygen therapy increases the bactericidal effects of the antibiotic ciprofloxacin on Pseudomonas aeruginosa biofilm, a common and difficult-to-treat pathogen, especially in chronic lung disease and wounds.
And another example?
In a study using the antibiotic tobramycin to treat Staphylococcus aureus endocarditis infection of the heart valve in a rat model, adjunctive HBO2 reduced the bacterial load in the aortic valve, myocardium, and spleen compared to tobramycin alone. This strongly suggests HBO2 can enhance antibiotic effectiveness against bacteria living in these protected biofilm structures and in difficult-to-penetrate tissues.
That's pretty significant clinically.
Yeah.
And given that bacterial biofilms are a huge problem in patients with chronic wounds.
Right. The source mentions that at least one study has demonstrated that hyperbaric oxygen therapy has some direct efficacy in killing these biofilms, which would contribute to improved wound healing in addition to its many other positive effects on tissue oxygenation and neovascularization.
Okay, micro recap for Section 4. Hyperbaric oxygen therapy exhibits distinct antibacterial effects. It's directly bactericidal against obligate anaerobes due to their lack of ROS detoxifying enzymes.
But acts indirectly against aerobic bacteria like Staph aureus, especially in poorly oxygenated sites like bone. There, HBO2 increases local oxygen tension to enable the host's immune cells, specifically neutrophils, to perform oxygen-dependent killing.
We saw how HBO2 boosts neutrophil respiratory burst and phagocytosis. A complex balance involves HBO2 enhancing antimicrobial activity while simultaneously promoting apoptosis to resolve inflammation and aid healing.
And finally, HBO2 shows promise in enhancing the efficacy of certain antibiotics against resistant bacterial biofilms.
Moving now to one of the most pervasive and clinically relevant areas affected by hyperbaric oxygen therapy, its multifaceted effects on inflammation. Appropriately regulating inflammatory molecules has the crucial advantage of limiting the extension of tissue injury following various insults, whether traumatic, ischemic, or infectious.
Yeah, controlling inflammation is key. Both animal and human research cited in the source provide consistent evidence that hyperbaric oxygen therapy significantly lessens several key inflammatory markers. These include reductions in leukocyte sequestration, the problematic sticking of white blood cells to the vascular endothelium, similar to the neutrophil adherence we discussed earlier.
Okay, what else?
It also lowers the levels of potent pro-inflammatory cytokines such as tumor necrosis factor, or TNF, and interleukin-6, or IL-6, which are major drivers of the inflammatory cascade.
Additionally, HBO2 decreases the expression of crucial adhesion molecules like intercellular adhesion molecule 1, or ICAM1, and CD18, which are involved in those detrimental leukocyte endothelial interactions.
It also reduces tissue myeloperoxidase activity, an enzyme released by neutrophils that contributes to tissue damage during inflammation, and lipid peroxidation, a marker of oxidative damage to cell membranes that occurs during inflammation. These are all specific, measurable targets that HBO2 appears to modulate towards a less inflammatory state.
What's particularly interesting is the diverse and sometimes seemingly contradictory effects HBO2 has on cytokine production, indicating a complex regulatory role rather than a simple blanket suppression of all immune signals. While many pro-inflammatory markers are reduced, other factors are upregulated.
Like what?
For instance, tying back to wound healing, HBO2 is shown to upregulate the synthesis of fibroblast growth factors, or FGF, and collagen synthesis. These are crucial for tissue repair and building new matrix. So it dampens some inflammation but boosts repair signals.
Okay. And in specific clinical conditions, HBO2 leads to a measurable reduction in certain inflammatory cytokines. In patients with Crohn's disease, a chronic inflammatory bowel condition, HBO2 therapy has been shown to reduce levels of interleukin-1, interleukin-6, and tumor necrosis factor alpha.
And it also effectively reduces heat stroke-induced plasma tumor necrosis factor alpha overproduction, indicating an ability to modulate systemic inflammatory responses in diverse scenarios.
Now, the source highlights a particularly fascinating pattern for certain growth factors that are absolutely crucial for tissue repair and neovascularization. Vascular endothelial growth factor, or VEGF, which stimulates new blood vessel formation, is upregulated not only by hypoxia, the classical stimulus, but also by the hyperoxia achieved with hyperbaric oxygen therapy.
Both low and high oxygen trigger it.
It seems so. Similarly, the effects of transforming growth factor beta-1, or TGF beta-1, and platelet-derived growth factor beta, or PDGF beta, both key players in wound healing and tissue remodeling, are enhanced by HBO2.
VEGF, TGF beta-1, and PDGF beta exhibit what is termed a biphasic release pattern. Their production and release are stimulated by both conditions, hypoxia and hyperoxia. This demonstrates a nonlinear response to oxygen tension, suggesting that these crucial signaling pathways can be activated by oxygen levels at either extreme of the physiological range.
It's not just about needing some oxygen, it's about signaling under conditions of extreme oxygen availability or deprivation. Quite sophisticated.
And to add another layer of complexity and benefit, the activity of the released vascular endothelial growth factor is further enhanced during the state of hyperoxia. So, HBO2 not only helps trigger its production, but also makes the resulting growth factor more potent in stimulating vessel formation.
Okay, so it's complex regulation. While the precise molecular mechanisms underlying all these intricate wound healing processes, involving this complex interplay of cytokines and growth factors, remain subjects of ongoing research, several studies have consistently shown that hyperbaric oxygen therapy can lead to increased production of nitric oxide, or NO, via the activation of NO syntheses.
Nitric oxide again. It seems to pop up everywhere.
It's a crucial signaling molecule. And this increased nitric oxide production strongly connects back to a key mechanism we discussed earlier regarding neutrophil adherence.
The S-nitrosylation.
Exactly. The same research group that provided evidence for the inhibition of neutrophil sticking also showed that a post-translational modification of actin occurs following hyperoxia. This modification is the S-nitrosylation of beta-actin, which is likely mediated by the generation of nitric oxide, specifically by inducible NO synthase, or INOS, under these specific hyperbaric conditions.
So the hyperbaric oxygen therapy-induced increase in nitric oxide production appears to be the crucial link that causes that specific S-nitrosylation modification to the beta-actin component of the neutrophil cytoskeleton. This structural change then impairs their ability to adhere to the endothelium.
Makes sense. Furthermore, studies have shown that hyperbaric oxygen therapy treatment leads to increased nitric oxide production, specifically within the proximity of a healing wound. This local increase in NO is directly correlated with positive wound healing outcomes, including increased granulation, tissue deposition, the formation of healthy connective tissue needed to fill the wound void.
Enhanced epidermal migration, the skin cells moving across the wound surface to close it, and overall improved wound closure rates. Imagine nitric oxide acting locally as a signaling molecule to facilitate these crucial steps in tissue repair.
To delve a little deeper into how that S-nitrosylation of beta-actin impacts neutrophil adhesion, the nitrosylation of the cysteine moiety's specific amino acid residues on the actin protein changes its conformation and effectively disrupts the formation of actin-integrin complexes. Integrins are the cell surface receptors on neutrophils that physically bind to adhesion molecules on the endothelial cells, forming the critical link for sticking.
So by messing with the internal anchor point, the external sticking is reduced.
That's the idea. By disrupting these intercellular actin-integrin connections via S-nitrosylation, the nitrosylation ultimately impairs the neutrophil endothelial cell adhesion. The source brings this together. Hyperbaric oxygen therapy reduces neutrophil adhesion to endothelial cells through a dual mechanism. It reduces the expression of endothelial adhesion molecules themselves, making the vessel lining less sticky, and it impairs the function of neutrophil adhesion molecules, the beta-2 integrins mediated by that S-nitrosylation resulting from HBO2-induced inos-derived nitric oxide production.
The clinical implication here is highly significant, especially in chronic wounds, isn't it? This impaired neutrophil adhesion directly reduces the persistent inflammatory burden within the chronic wound environment. Excessive, prolonged neutrophil-driven inflammation is a major barrier to wound healing.
Absolutely. Therefore, this mechanism provides a clear molecular pathway explaining how hyperbaric oxygen therapy treatment reduces inflammation and promotes healing, particularly in difficult chronic wounds like diabetic ulcers.
Okay, micro recap for Section 5. Hyperbaric oxygen therapy has widespread anti-inflammatory effects, shown by reduced levels of inflammatory markers and adhesion molecules like TNF, IL-6, and ICAM-1.
It modulates cytokine production, downregulating some pro-inflammatory signals while upregulating or enhancing others like FGF and the biphasic growth factors VEGF, TGF-beta1, and PDGF-beta.
A key mediator is increased nitric oxide production, which leads to S-nitrosylation of beta-actin. This modification impairs neutrophil adhesion to the endothelium, reducing inflammatory cell infiltration and the associated tissue damage, a primary mechanism for its anti-inflammatory effects, especially beneficial in chronic wounds.
Right. Now, let's explore some fascinating emerging mechanisms of action areas of active research that are deepening our understanding of HBO2's diverse biological impacts, including a more nuanced view of its interaction with oxidative stress, its potential role in managing chronic pain, and its influence on bone formation or osteogenesis.
We've already established that hyperbaric oxygen therapy exposure results in the production of reactive oxygen species, or ROS, and this is a dose-dependent phenomena. Higher pressures and longer durations generally lead to more ROS.
Yes, but while ROS are often associated with cellular damage, some investigators propose that, paradoxically, hyperbaric oxygen therapy exposure may actually reduce overall oxidative stress in certain contexts.
How?
One proposed mechanism suggests this might occur by altering the initiation process of caspase-3-like activity, which is a crucial enzyme involved in apoptosis-programmed cell death and cellular responses to stress. The source also mentions that superoxide involvement might contribute to HBO2's therapeutic effects, linking back to that initial ROS discussion as potential signaling molecules.
Okay, so it's complex, but here's another crucial point that balances the picture regarding ROS. Despite generating reactive oxygen species, hyperbaric oxygen therapy exposure consistently preserves mitochondrial activities. Mitochondria, the cell's power generators, are notoriously sensitive to oxidative damage, so this protective effect is vital for cell survival and function.
How does it protect the mitochondria while making ROS?
The mechanism proposed for this mitochondrial protection is that HBO2 is associated with increased expression of the anti-apoptotic protein BCL2, specifically at the wound site. BCL2 is a key intracellular regulator that prevents cells from initiating programmed cell death.
So by increasing BCL2 levels, HBO2 consequently prevents excessive or unnecessary apoptosis, helping to maintain the population of viable cells needed for tissue repair and regeneration.
It suggests that HBO2 generates controlled, beneficial signaling ROS, while simultaneously triggering cellular defense mechanisms that protect vital organelles like mitochondria and prevent undesirable cell loss. A very delicate balance.
Okay, moving to another challenging clinical area, neuropathic pain, chronic pain that arises from damage or disease affecting the somatosensory nervous system. Inflammation and immune processes are known contributors to neuropathic pain and hyperalgesia, an exaggerated response to painful stimuli, or pain from normally non-painful stimuli.
Cytokines, those signaling molecules we discussed in inflammation, are implicated here. They could trigger or fasten the sensitization of afferent nerve fibers, the nerves that carry pain signals to the brain, even without a demonstrable structural sensory injury. This implies inflammation and cytokines alone can make pain pathways hypersensitive.
Right, and findings from animal models are starting to provide insight into whether HBO2 can modulate this. Thompson and colleagues, using rat models, demonstrated that hyperbaric oxygen therapy could reduce both pain behaviors and mechanical hypersensitivity, increased pain response to touch or pressure.
What do they find specifically?
They found that repetitive and long-term HBO2 exposure resulted in transient inhibition of thermal hyperalgesia, increased pain from heat, and thermal mechanical hypersensitivity, respectively.
Okay, and others.
Zhao et al. Also explored the relationship between HBO2 and anti-nociceptive reaction, the biological processes that reduce pain. They demonstrated that even a single HBO2 exposure could produce a short-term anti-nociceptive effect and inhibit mechanical and thermal hyperalgesia.
However, they also presented a specific complex finding. Several HBO2 exposures resulted in the inhibition of astrocyte activation. Astrocytes are a type of glial cell in the brain and spinal cord often involved in the inflammatory response to nerve injury with a consequent worsening of neuropathic pain.
Wait, inhibiting astrocytes made the pain worse?
In that specific model, yes. This is a specific, potentially counterintuitive observation that highlights the complex and still debated nature of glial cell involvement in pain and how HBO2 interacts with these cells. It suggests that inhibiting astrocytes might not always be beneficial in chronic pain, or perhaps depends on the timing or specific context. Very complex biology.
Definitely. Regarding the connection between HBO2, cytokines, and pain, studies showed that hyperbaric oxygen therapy significantly decreased the production of both prostaglandin E2 and interleukin-1 beta, both well-known inflammatory mediators that sensitize pain pathways.
But, as the source notes, this specific link is still debated in the scientific literature. Other studies investigating HBO2's effects on neuropathic pain showed it relieved pain by reducing tumor necrosis factor alpha production, but not interleukin-1 beta. So, conflicting results on the specific cytokines involved.
The authors suggest that these different mechanisms affecting IL-1 beta-PG2 in some cases and TNF-alpha in others might be simultaneously operative. This is plausible given the known complex, often synergistic regulatory processes involving TNF-alpha and IL-1 in causing neuropathic pain sensitization.
So maybe HBO2 hits multiple targets in the pain network.
That's a possibility. Now, reconnecting to an earlier important theme, the nitric oxide connection appears particularly relevant in pain modulation. The Zhao study found that specific inhibition of NO production led to a vanishing of the short-term anti-nociceptive action of hyperbaric oxygen therapy.
So NO is needed for the pain relief.
It seems so. Thus, it has been proposed that nitric oxide synthesis induced by hyperbaric oxygen therapy is relevant in lightening hyperalgesia. And significantly, the source states that a recent study confirmed that this is the main hyperbaric oxygen therapy mechanism of action regarding the anti-nociceptive effect.
Okay, so the NO link for pain relief is getting stronger evidence.
It appears so. Shifting focus now to bone tissue, the promotion of osteogenesis, the formation of new bone, is another area where hyperbaric oxygen therapy shows clinical and mechanistic promise. Several clinical studies, as cited in the source, support the benefits of HBO2 in patients afflicted with aseptic hip osteonecrosis and aseptic condylar knee necrosis.
These are conditions where bone tissue dies due to disrupted blood supply, vascular necrosis, not due to infection. Tough conditions to treat.
Very. Camporesi and colleagues, authors of the source chapter, provided compelling clinical support in a 7-year follow-up study. In a small group of patients with aseptic necrosis of the femoral head, the ball joint of the hip, treated with a series of hyperbaric oxygen therapy sessions at 2 atmospheres absolute, or 202.6 kilopascals, they demonstrated a remarkable reversal of the necrosis based on long-term follow-up.
That's strong evidence for a therapeutic effect in a difficult condition. But do we know exactly how it works?
Well, similar to other emerging areas, the source acknowledges that the precise underlying mechanisms of action responsible for HBO2's beneficial effect in osteonecrosis are still unclear, framing this as a powerful clinical observation awaiting full mechanistic explanation at the cellular and molecular level.
But there must be some clues.
There are. Recent mechanistic data are starting to provide clues. Studies demonstrate that intermittent supplementation of oxygen delivered under pressure to hypoxic bone tissue, which occurs in osteocrosis, provides stimulation to osteoblasts, the specialized cells responsible for building new bone matrix. This leads to measurable bone tissue regeneration.
So more oxygen helps the bone-building cells directly.
That seems to be part of it. Researchers are also investigating hyperbaric oxygen therapy's influence on the other side of bone remodeling. Osteoclasts, the cells that resorb or break down bone tissue.
What did they find about osteoclasts?
A study examined the effect of HbO2 pressure and hyperoxia on receptor activator of nuclear factor kappa B-induced or ANKL-induced osteoclast formation. ANKL signaling is a major pathway promoting osteoclast differentiation and activity. This study was performed in raw 264.7 cells and human peripheral blood monocytes, or PBMC, both of which can differentiate into osteoclasts.
In another study, using magnetic resonance imaging, or MRI, obtained a baseline, and about 1 year after hyperbaric oxygen therapy treatments to follow lesion size in patients with a vascular necrosis of the femoral head, also investigated potential mechanisms. They looked specifically at whether HbO2 upregulated serum osteoprotogerin, or OPG.
What's osteoprotogerin?
OPG is a naturally occurring molecule that acts as a decoy receptor for AN and COL, effectively blocking RAN-COL signaling and thus inhibiting osteoclast formation and activity. Upregulating OPG would therefore inhibit bone resorption.
Ah, so blocking the bone breakdown signal.
Potentially, yes. They investigated if HbO2 did that and if it correlated with inhibition of osteoclast activation.
Now, the same group that demonstrated the clinical effects in a vascular necrosis of the femoral head also showed that hyperbaric oxygen therapy results in a clear anti-inflammatory action in these specific patients. This was demonstrated by a decreased amount of circulating pro-inflammatory cytokines, specifically tumor necrosis factor alpha and interleukin-6.
And how does inflammation relate to bone loss here?
This anti-inflammatory effect is highly relevant to bone remodeling because TNF-alpha and IL-6 are known as key bone-resorbing cytokines. They directly stimulate osteoclast activity and inhibit osteoblast function.
So they tip the balance towards bone breakdown.
Exactly. The source suggests that hyperbaric oxygen therapy's action on these cytokines, reducing their levels and thus mitigating their potent synergistic bone-resorting effects, could be the primary mechanism responsible for the beneficial clinical effects observed in osteonecrosis.
So it's not just about stimulating new bone formation, but potentially interrupting the excessive bone breakdown driven by chronic inflammation and cytokine signaling in the necrotic area. A dual action again.
It seems likely. The source appropriately concludes this section by reiterating that multiple mechanisms of the beneficial action of hyperbaric oxygen therapy exposure continue to be discussed and actively elucidated in the scientific literature. It's a rapidly evolving understanding.
Okay, micro recap for Section 6. We've delved into emerging mechanisms. Regarding oxidative stress, while HbO2 produces ROS, it seems to paradoxically preserve mitochondrial function by increasing the anti-apoptotic protein BCL2, suggesting a controlled signaling role for ROS balanced by cellular protection.
In neuropathic pain, debated but growing evidence suggests HbO2 reduces pain and hypersensitivity, possibly via reducing inflammatory mediators, with increasing support for a key role of HbO2-induced nitric oxide synthesis.
Finally, in osteogenesis, clinical benefit in osteonecrosis points to mechanisms including direct osteoblast stimulation by oxygen, potential osteoclast inhibition via OPG upregulation, and crucially, an anti-inflammatory effect reducing potent bone-resorbing cytokines like TNF-alpha and IL-6.
Right. Now we arrive at a truly groundbreaking concept presented towards the end of this source chapter, the putative transcellular transfer of mitochondria. This idea challenges a long-held fundamental belief in cell biology about how cells maintain their energy production machinery.
What was the old belief?
Until relatively recently, the prevailing thought was that mitochondria, the powerhouses of virtually all eukaryotic cells, would remain housed intracellularly, confined within the cytoplasm of the specific cell they were created in for the entire life duration of that cell. Mitochondria were seen as static, inherited organelles.
But strikingly, new evidence, compiled and referenced in this source, supports a dramatically different and dynamic view. That active intercellular exchange of mitochondria and indeed other intracellular organelles doesn't just happen. It actually continues during normal tissue growth and, perhaps even more importantly, clinically appears significantly enhanced in various pathological conditions where tissues are stressed or injured.
Cells are sharing mitochondria. That's wild.
It is a major paradigm shift in how we understand cellular health and repair.
And this enhanced exchange has been demonstrated in diverse pathologies affecting critical organs such as the lungs, kidneys, and myocardium, the heart muscle. However, the source specifically highlights that this mechanism has been shown to be particularly relevant in the repair and recovery of the ischemic brain, tissue damaged by stroke or other lack of blood flow.
A later paper referenced within the source demonstrated that mitochondrial transfer from bone marrow-derived mesenchymal stem cells, or MSCs, multipotent stromal cells that can differentiate into various cell types and are known for their regenerative potential, can effectively reduce acute lung injury in animals challenged by bacterial infection.
MSCs giving mitochondria to lung cells.
Seems like it. They also suggested that MSCs could prevent volume-induced lung injury, or villus-I, a type of lung damage that can occur in healthy rats subjected to high-volume mechanical ventilation, a model relevant to critical care medicine. The implication is that MSCs are donating mitochondria to injured lung cells to help them survive.
The potential clinical applications of this phenomenon are gaining significant traction worldwide. A review by Chen and colleagues summarized the future clinical applications of therapeutic mitochondrial transplantation, specifically collecting a register of human clinical trials that had been initiated exploring this very concept.
So people are already trying this in humans.
It underscores that transferring mitochondria is moving rapidly from experimental observation to potential human therapy.
Wow. A recent commentary updated the present state of mitochondrial research, detailing the fascinating mechanisms by which this intercellular mitochondrial movement between different cells and tissues can physically occur. One key mechanism is via microvesicles, or MVs, tiny membrane-bound sacs that bud off from cells and can contain and transport various cellular contents, including mitochondria, to recipient cells.
Like little mitochondrial delivery packages?
Exactly. Another mechanism, perhaps even more visually striking, is via tunneling nanotube, or TNT, transfer. These are direct, thin, open-ended membrane tubes that form physical connections between cells, allowing for the direct passage of organelles, including mitochondria, cytoplasm, and even signaling molecules, from one cell to another.
Cells building microscopic pipelines to share their energy factories or communicate directly. Incredible.
The source highlights the duality in the purpose of this transfer. It's been clearly demonstrated for the transfer of healthy, functional mitochondria. This serves as a mechanism of functional renewal in diseased or damaged cells. A healthy cell can donate its energetic organelles to a stressed neighbor to boost its survival and function.
But importantly, the source also notes that this transfer can occur for degenerate or damaged mitochondria, and this type of transfer can unfortunately contribute to the propagation of cell pathology, such as in metastatic cancer cells.
So cancer cells can use this too?
Potentially. Cancer cells might acquire damaged mitochondria or shed their own damaged ones, or acquire functional ones from the microenvironment to enhance their survival, proliferation, or resistance to therapy.
A comprehensive review by Cheng et al. Specifically focused on mesenchymal stem cells and their remarkable ability to provide mitochondrial transfer.
This review underlined the significant improvement in clinical outcomes obtained in diverse animal models of alveolar cell pathology and pulmonary infections where MSCs were administered, strongly suggesting that the mitochondrial transfer capability of MSCs was a key factor in their therapeutic effect.
What else did it show?
Further demonstrations listed included improving the function of cardiomyocytes, heart muscle cells after ischemia, and the transfer of mitochondria specifically via astrocytes, those supportive brain glial cells, into ischemic brain cells, highlighting this mechanism in the context of stroke recovery.
However, this comprehensive review also included a critical warning, particularly relevant for cancer researchers. Cancer cells may enhance their ability to produce metastases and induce chemoresistance by shifting damaged mitochondria between cells and even by selective loss of donor nuclei after complete cell fusion events with other cells.
That's a major concern.
It is. This observation that cancer cells can spread their resilience or acquire chemoresistance through this transfer mechanism is profoundly important for understanding cancer biology and therapeutic failure. But, as the source provocatively points out, this detrimental transfer mechanism observed in cancer might also be utilized as a future clinical tool.
How so? Turn the bad mechanism against them.
Potentially. Thinking ahead, identifying and understanding this detrimental transfer mechanism in cancer could reveal specific pharmaceutical blockage sites, targets, where we could develop drugs to interrupt this process. By blocking cancer cells from acquiring resilience or spreading damage through mitochondrial exchange, we could potentially limit metastasis and enhance the effectiveness of chemotherapy, thus indirectly helping to restore healthy tissue by controlling the cancerous spread.
Fascinating. Another interesting review cited in the source by Crew et al. Underlines how interorgan transport of mitochondria can be generated from the abundant supply provided by adipocytes or fat cells and influence distant organs.
Fat cells donating mitochondria.
Yes, they highlight that adipocytes can readily donate microvesicle encapsulated mitochondria, even from oxidatively damaged adipocytes, into the circulation. These vesicles containing mitochondria can then be taken up by cells in distant tissues, for example, in cardiac tissue.
And what's the implication of that?
This uptake and potential functional integration of adipocyte-derived mitochondria into cardiomyocytes might offer a fascinating hypothesis. It could potentially explain the paradoxical resistance to cardiac ischemia sometimes observed clinically in patients with obesity.
Wait, obesity protecting the heart via mitochondria from fat. That's unexpected.
While obesity is associated with many negative health outcomes, this specific mitochondrial transfer mechanism could be a previously unrecognized protective pathway for the heart in that population. Just a hypothesis at this stage, but intriguing.
Very. A broad review article by Liu et al. Provides specific helpful tables summarizing known instances of intercellular mitochondrial transfer under both physiological conditions, occurring naturally between different cells and between different tissues, and in a long list of various pathological states, supported by an extensive list of references.
This comprehensive review discusses all the known mechanisms of transfer that we've touched on, microvesicles and tunneling nanotubes, and importantly, explores the various stimuli that are necessary to evoke the beginning or enhancement of this intercellular transfer process.
The evolution of this novel and exciting field of intercellular mitochondrial transfer holds significant potential. It could provide entirely new clinical strategies for maintaining the health and function of organs suffering from aging or ischemic damage by boosting their energy capacity.
And hopefully, as we discussed, it could offer a new mechanism to support the effectiveness of chemotherapy and limit cancer expansion by targeting these transfer pathways.
Now, this is where the concept of mitochondrial transfer specifically intersects with hyperbaric oxygen therapy, bringing our deep dive full circle. The source references a different opinion paper and a more comprehensive review that specifically appreciate the effect of mitochondrial transfer as a therapeutic strategy against acute ischemic stroke.
How does it relate to stroke?
These papers discuss how healthy mitochondria can be transferred from astrocytes, those crucial supportive glial cells in the brain, to stroke cells, neurons, and other brain cells damaged by the insufficient blood flow, specifically during the critical phase of the evolution of the ischemic penumbra, the area of brain tissue surrounding the core infarct that is still potentially salvageable with timely intervention. Astrocytes trying to rescue neurons.
Okay. And the HBO2 connection?
Lippert and Borlongen, authors of one of these papers, extend these concepts to provide an exciting potential explanation for the protective, prophylactic use of hyperbaric oxygen pretreatment. Their paper specifically attempts to elucidate a potential mechanism of action for giving hyperbaric oxygen therapy before an anticipated or potential ischemic event.
Preconditioning with HBO2.
Exactly. It demonstrates how a pre-exposure to hyperbaric oxygen therapy, given hours or days preceding the exposure of a tissue to a state of anoxia, a complete lack of oxygen, mimicking a severe ischemic insult, could actually transfer a resistance mechanism to that tissue, making it more resilient to the subsequent injury.
It's as if the HBO2 pre-treatment primes or trains the cells, conferring a lasting protection. But how? The oxygen effect is temporary.
Right. And here's where they provided truly compelling evidence for this link. Recognizing that oxygen levels inside a tissue are fleeting and only last for a relatively short time after a hyperbaric oxygen session, the authors needed to find a more enduring mechanism to explain the long-lasting protective effect of this preconditioning. They visualized directly the mitochondrial transfer between cells that was induced by this hyperbaric oxygen pretreatment.
They actually saw mitochondria moving between cells after HBO2.
Yes, they saw mitochondria moving from one cell to another in response to the HBO2 stimulus.
That's incredible evidence.
It is. This process, triggered by the hyperbaric oxygen pretreatment before the ischemic insult, results in the transfer of healthy mitochondria to recipient cells. Furthermore, it induces increased resistance of those receiving cells, not only to the lack of oxygen itself, but also to the damaging inflammatory response that is typical of both ischemia and traumatic brain injury, or TBI.
So it's a dual benefit, providing critical energy components and dampening the subsequent inflammatory damage.
Exactly. And the quantification of this effect is striking. The source notes that this preconditioning process, induced by HBO2, doubles the salvage rate of the cells subjected to experimental ischemia compared to control cells.
Doubles the survival rate. That's huge.
It's a massive functional benefit and strongly suggests that the enhanced mitochondrial transfer is a key mechanism underpinning the observed protection.
And this direct visualization and compelling evidence that hyperbaric oxygen therapy pretreatment induces intercellular mitochondrial transfer, leading to double the salvage rate and increased resistance to injury, might very well provide a fundamental explanation for the significant and lasting protective effects sometimes observed clinically from hyperbaric oxygen preconditioning strategies in settings like cardiac surgery or potentially neurosurgery.
So to summarize this truly cutting-edge final section, the source concludes by stating that intercellular mitochondrial transfer is a frequent mechanism associated with various physiological and pathological activities of the body. And crucially, this complex and beneficial process has been specifically demonstrated to be enhanced after hyperbaric oxygen therapy exposure.
And it may play a significant role in the restoration of normal physiological functions in damaged or stressed tissues, particularly in settings of ischemia and injury, potentially explaining the observed benefits of HbO2 preconditioning.
Okay, let's pull all of these threads together into our mega recap, synthesizing the major mechanistic themes we've explored from this comprehensive chapter. We started at the absolute base layer with the foundational physics and gas laws, Boyle, Dalton, and Henry.
Right, which govern how elevated ambient pressure and 100% oxygen dramatically increase dissolved oxygen in plasma, effectively bypassing normal hemoglobin transport limitations, as visually represented in Figure 1.
We clearly differentiated the rapid bubble compressing effects crucial for acute conditions like gas embolism from the more profound, cumulative, and enduring pharmacological benefits that develop over multiple hyperbaric oxygen therapy sessions for chronic pathologies.
We established the central yet complex role of reactive oxygen species. We saw them not just as agents of potential toxicity, but as crucial signaling molecules driving many therapeutic pathways, involved in everything from growth factor stimulation to the S-nitrosylation that regulates neutrophil function.
We then ascended to the tissue level, detailing the mechanisms of neovascularization, how HbO2 promotes both angiogenesis and stem cell recruitment to accelerate wound healing. A highlight here was the paradoxical stabilization of hypoxia-inducible factor, or HIF, by HbO2-induced reactive oxygen species via the thyrodoxine pathway.
Alongside stimulation of growth factors like FGF and the fascinating biphasic response of VEGF, TGF-beta1, and PDGF-beta to oxygen tension.
We explored how hyperbaric oxygen therapy provides crucial protection in ischemic tissue by primarily inhibiting neutrophil adherence to the endothelium. This is mediated by S-nitrosylation of beta-actin, a process linked to nitric oxide production induced by HbO2.
And is clinically vital because it selectively prevents damaging sticking while preserving the neutrophil's essential ability to fight infection, a key advantage over other anti-integrin approaches. We also touched on modulation of monocyte and macrophage activity as another anti-inflammatory pathway.
We discussed the distinct antibacterial actions, contrasting the direct, pressure-dependent killing of obligate anaerobes who lack detoxification enzymes with the indirect immune-mediated effect on aerobic bacteria like Staphylococcus aureus. In conditions like osteomyelitis, HbO2 doesn't directly kill the staph, but increases local tissue oxygen tension within the bone marrow to enable the host neutrophils to effectively carry out oxygen-dependent killing.
We also saw the complex interplay of HbO2 enhancing antimicrobial activity while simultaneously promoting apoptosis to resolve inflammation and aid healing, and the potential synergy with antibiotics against resistant bacterial biofilms.
We delved into the broader systemic anti-inflammatory effects, noting how HbO2 consistently reduces key circulating inflammatory markers and adhesion molecules. It modulates cytokine production in complex ways, downregulating some pro-inflammatory signals while upregulating others crucial for repair.
We reinforced the central role of increased nitric oxide production induced by HbO2, which drives the S-nitrosylation mechanism responsible for reduced neutrophil adhesion, directly contributing to a reduced inflammatory burden, particularly beneficial in chronic wounds.
We then explored some truly emerging mechanisms. In pain pathways, growing evidence, though still debated in specifics, suggests HbO2 reduces neuropathic pain and hypersensitivity, with significant support for the nitric oxide pathway induced by HbO2 as a key mediator, alongside complex effects on inflammatory cytokines and potential interactions with astrocytes.
In osteogenesis, Clinical evidence of benefit in osteonecrosis points to mechanisms including direct osteoblast stimulation by improved oxygen, potential inhibition of bone-resorbing osteoclasts via upregulation of osteoprotein or OPG, and crucially, the anti-inflammatory action reducing potent bone-resorbing cytokines like TNF-alpha and IL-6.
And finally, we ventured into the frontier concept of intercellular mitochondrial transfer, a real paradigm shift in cell biology. We learned about its natural occurrence, its significant enhancement in disease states, the fascinating physical mechanisms of transfer via microvesicles and tunneling nanotubes.
And its dual potential for either beneficial cell renewal or detrimental pathology propagation as seen in certain cancers.
Most importantly for this deep dive, we saw the compelling evidence that hyperbaric oxygen preconditioning specifically stimulates this mitochondrial transfer between cells, enhancing the resilience and energy capacity of recipient cells to subsequent ischemic or traumatic injury. This process, which was visualized directly, doubles the salvage rate in models and provides a powerful potential explanation for the long-term protective effects observed with HbO2 preconditioning.
Phew. This deep dive into the source material by Bosco, Vizzani, and Camporese truly lays bare the incredible complexity and interconnectedness of hyperbaric oxygen therapy's mechanisms. It's abundantly clear that this isn't a simple therapy working through one or two pathways, but rather a multifaceted intervention acting simultaneously across basic physics, complex cellular signaling involving ROS and NO, immune cell modulation, growth factor regulation, and even groundbreaking intercellular organelle transfer.
And understanding this detailed why and how, drawn directly from expert synthesis of the literature, is absolutely essential for you, the specialist clinician, in appropriately applying this therapy, selecting the right patients, optimizing protocols, and appreciating the dynamic research landscape that continues to elucidate these fascinating processes.
Absolutely.
So, having unpacked this incredible detail from the fundamental gas laws all the way to the cutting-edge concept of HbO2-induced mitochondrial transfer and its impact on cellular resilience, here's a final thought to ponder. If hyperbaric oxygen therapy preconditioning can, by stimulating mitochondrial transfer, double the salvage rate and transfer resistance mechanisms in models of acute injury like ischemia and traumatic brain injury, how might this specific mechanism fundamentally change our approach to conditioning patients before planned high-risk surgeries or procedures where ischemia is a significant risk?
You mean, could this open the door to prophylactic HbO2 becoming a standard part of preoperative protocols in certain settings?
Exactly. Something to think about.
Definitely food for thought. There's always more to learn, and appreciating these multiple perspectives and complex mechanisms enriches our understanding of hyperbaric oxygen therapy immensely. Thanks for joining us for this deep dive.